So my name is Dr. Thomas Berk. I'm a neurologist and headache specialist at NYU. I am very happy to discuss and to present the first in a series of webinars from the American Migraine Foundation. The title of this webinar is the current migraine medications, the definition and the differentiation between preventive, abortive, and rescue medicine. So we're going to talk about all the different types of medicines that we use for migraine and the categories that they are in. So back to the second slide where I was and nobody could hear me. Okay. So again, the same topic. When we talk about medications that we use for migraine, for the most part, what we need to consider is what the purpose of the medications is. Some medications primarily are there, as acute treatment or abortive treatment. Some medications are there as preventive treatment, and some are kind of in between. And we're going to talk about these three different categories of medications for migraine. What's important when you discuss treatment options with your specialist is to understand precisely what it is that you're trying to go after. For people who have very infrequent migraines, what you really need sometimes is something that's going to be very effective acutely or abortively to stop a migraine in its tracks when it comes. People who have more frequent migraines are going to need not only an effective medicine to stop a migraine when it comes, but sometimes even some kind of preventive option. The majority of these are daily to decrease the frequency of migraine. In rare situations, when you do have infrequent migraines, but the migraines are so severe, we'll actually recommend a preventive medication just to decrease the severity of infrequent migraines. So what is the cutoff for recommending preventive medicines? Typically what we consider as the cutoff is about a migraine a week, or 4 to 5 migraine days per month. If you're somebody who has one really severe prolonged migraine, that might actually be you. If you have a week of migraine or a little bit less than that every single month, it might be worth considering prevention at that point. If you just have 4 or 5 days of disparate migraines per month, you might want to consider that also. At fewer than 4 or 5 migraines per month, and sometimes at about that number, many doctors, many specialists will start to recommend vitamin preventives. There are 3 safe and effective supplements that were studied specifically in migraine prevention and are very effective, especially at low frequencies. And the advantage to using supplements over medication for the most part is side effect profile, because these really are supplements, and even though you can have some side effect with some of these, they're generally much better tolerated. And if it means that you don't necessarily have to be on a medicine every single day, it could be a lot better for you. The 3 are magnesium, and that's typically given as magnesium oxide. That's really what's been studied. There are a number of other formulations of magnesium. Some are better tolerated than the oxide formulation, which can sometimes loosen up your stool. Sometimes that's good, sometimes that's not. Some other formulations of magnesium are given regularly by other practitioners, and sometimes I'll even recommend other kinds of magnesium, but for the most part, oxide's been what's been studied best in the headache literature and in evidence. Riboflavin at 400 milligrams daily is the other, is one other supplement that is recommended for the prevention of migraine, and coenzyme Q10 100 milligrams daily. Now, there are a number of other supplements that can be recommended, and there are varying degrees of evidence. For instance, many people recommend things like feverfew. Boswellia is recommended for some kinds of headache, much less so migraine. People sometimes are put on turmeric and things like that. The evidence is not as strong for those. There was a supplement that was very in vogue just a few years ago. It was called Butterbur. And although it's very effective, it is associated with liver toxicity, and it is, for the most part, not recommended unless you are willing to really follow through with getting liver function tests, blood tests every so often. So for the most part, it is not recommended in the headache community anymore. Before we even get into medicines, I think it's very important to discuss lifestyle modifications, because when you think about the things that are worsening migraine, many times it's not just a medical question. Many times there are triggers that are clearly causing your migraines to get worse. Many times it's a sleep issue. And sometimes people can really find out that they have sleep apnea or some other sleep issue based on their worsening migraine. Getting exercise regularly, making sure that you eat and aren't dehydrated, all of these things can make a huge difference with regards to migraine triggering, and even relaxation techniques, things like yoga, meditation, biofeedback are extremely helpful in decreasing the frequency and severity of migraines, sometimes to the extent that certain medications can. So it's definitely something that is strongly recommended. And trying to figure out what your personal triggers are. And I think that it's very important for most people to realize that for most migraines, there isn't one individual trigger that's really the reason why you had this migraine. More often than not, it's a constellation of triggers happening. Basically, if you have migraine, and I think, I've said this before on some of the Facebook Lives, and I think it's worth visualizing this. You have a threshold that, when crossed, makes your brain go into migraine mode. So when, when you're a little bit stressed out, a little bit dehydrated, when you didn't sleep so well the night before, and then you ate something that is a little bit of a trigger for you, boom, that's when it happens. It's not often the case where it's literally just one thing, although it can. Sometimes hormonal fluctuation or like menstrual period, that can definitely be a trigger. And sometimes it's worth talking to either your OBGYN or your headache specialist even about ways that sometimes can actually help you around hormonal fluctuation as a trigger. Some other preventive treatments are things like transcranial magnetic stimulation. There's an eNeura device that was recently, not too recent now, it's been approved for the prevention of migraine and for abortive use in migraine with aura. There are transcutaneous stimulators, that's the Cephaly device. And there's even a vagus nerve stimulator that's been recently approved for the acute treatment of migraine pain. So those are some non-medical treatments. I'm just throwing them in there as non-medical things before getting into the weeds of medicines. So now let's actually talk about overall the different classes of medicines that we typically consider when we think about migraine prevention. Now, you'll see, I'm sure that a lot of people are saying, well, where are the CGRPs? I'm going to get there. Don't worry. For the most part, if you're going to start thinking about some kind of preventive treatment for migraine, most of the time you're going to be discussing medicines in one of these three classes. They're either blood pressure medicines, they are anti-seizure medicines, or they're antidepressants. The reason why these things work, obviously these classes of medicines have been studied specifically for the prevention of migraine. But the idea behind how they work, for the most part, is that they can help to regulate certain things that are dysregulated during migraine or with very frequent migraine. What happens in your brain when your brain goes into migraine mode is a whole biological phenomenon that's known as migraine. And there's dysregulation of the electrical activity of your brain, there's dysregulation of neurotransmitters in your brain, and to an extent also, there is dysregulation of the blood vessels around your brain. The thought behind each of these classes of medicines is that with better regulation of many of these, or each individual aspect of what happens in your brain during migraine, you can actually decrease the frequency and severity of migraine. So one of the things that we see, for instance, with beta blockers is that not only will you have some advantage with regards to migraine prevention or any of the other, blood pressure pills, it's that if somebody does have high blood pressure, well, then you can kill two birds with one stone. There is a downside to using these blood pressure pills, which is that the vast majority of the people that have migraine are relatively healthy young people who more often than not don't have high blood pressure. If somebody does have high blood pressure, you can certainly kill two birds with one stone. But sometimes we can't use the antihypertensives because it'll lower the blood pressure even further. One nice thing about using anti-seizure medicines is that sometimes they can help with other kinds of pain, like gabapentin can. Sometimes they can help with certain mood disorders, like Depakote can. They can absolutely not be used in pregnancy. Topiramate, a lot of times people like it also because it can cause some weight loss. The downside to using some of these medications is that, number one, like I was saying before, many of the patients that we see, most of the people that have migraine are otherwise young, healthy people. And especially we're talking about women of childbearing age. These are not necessarily medicines you want to be on during those years if you're thinking of becoming pregnant shortly. Sometimes they can even worsen mood. So that sometimes is a disadvantage in using that class of medicines. The advantage in using some kinds of antidepressants, specifically the TCA and SNRI type antidepressants, is that, so the names of those medicines are things like amitriptyline or Elavil, nortriptyline or Pamelor, the SNRIs or Cymbalta or Effexor. The advantage to those is that you can actually treat anxiety and depression pretty well. The disadvantage is that sometimes they can cause sleepiness or weight gain. And most of these medications also really shouldn't be used if you're considering pregnancy very soon. There are other classes of medications that we'll sometimes use preventively. Sometimes you'll see people do nerve blocks frequently. Rarely, although sometimes you'll actually see people use like high doses of certain anti-inflammatory antibiotics. So if somebody recommends that, it's not a crazy thing to do. It might be lower yield, but it's something that we'll recommend sometimes. And even sometimes we'll recommend anti-dementia medicines. There's something called memantine or Namenda, and that can actually be a very effective medicine. And it has a pretty safe profile in pregnancy, which is an advantage too. So obviously don't want to have to be on anything in pregnancy, but many people would say it's one of the safer options, as is nerve blocks. So those are the general classes of medicines that we typically discuss. There are, as I think many people know, a brand new class, there is a brand new class of medications that have come on the market for the prevention of migraine very recently. The first was approved just in May, and the last two only last month. The class of medications are called CGRP antagonists, and CGRP stands for calcitonin gene related peptide. It's one of a host of inflammatory neurotransmitters that propagate migraine. And by blocking either CGRP, this inflammatory neurotransmitter, or blocking the receptor that CGRP binds to, you can actually decrease the frequency and severity of migraine also. Most of these are once-a-month injections. One can be given as 3 injections over 3 months, but there is one latecomer to the game that's an IV infusion, and that may be something that over the course of the next year or so may become approved also. And many of you may actually be recommended that, or you may be recommended one of these new CGRP antagonists. The advantage to these treatments is that they happen to be exceptionally well tolerated for the most part, with very, very few exceptions. What we're seeing is a new class of preventive treatment that's specific for migraine. Going back to the last slide, I'm sure everyone noticed that none of these things say anti-migraine. What they all say is they say anti-hypertensive, blood pressure, right? Anti-epileptic, anti-seizure, but none of them are specific for migraine. And the advantage to the CGRP medicines is that they are specific for migraine. They have shown a significant benefit in many patients, even people now we're seeing who have been very refractory, who've tried multiple preventive medicines, few of which have made a difference for them at all. And it's been looked at specifically in chronic migraine. We'll talk a little bit about that, but that's where you have 15 or more migraine days per month. So that's the advantage. I'll tell you the downside, which is there is only, a handful of years worth of safety data for the CGRP medications. It's a new class of medicines. It's different than if a new anti-seizure or anti-hypertensive medicine came to the market. For the most part, we understand what the side effect profile would be long-term. Because these are brand new, what we know is only what we know. We know that patients have started these treatments, over the past few years in trials, and many have continued in each of the trials, and they seem to be tolerating it, over the next few years that they're taking it. They seem not to have long-term side effects. Based on animal data also, we don't see that there are long-term side effects. And from what we can extrapolate about the actual medication, we don't see any significant long-term side effects. But it's, there is a bit of a question out there. It's a risk-benefit, question, and what I usually recommend is that you speak to your individual doctor about, about whether these are going to be right for you or whether, some other kind of treatment is going to be best for you. There are stimulators that are relative newcomers also. I just spoke a little bit about the vagus nerve stimulator, a non-medical treatment. There's a vestibular nerve stimulator that's in trials. There's a sphenopalatine ganglion, try to say that 5 times fast, stimulator, which is something that people are using for cluster headache treatment. And these are also non-medical treatments that could be very safe for migraine also. So talking about why migraines worsen, and we talked a little bit about this just now. We talk about triggers like stress. We talk about some kinds of exposures like food. Weather changes are very, very classic. And one thing that we definitely see also is when you overuse the abortive medicines, sometimes you can have more frequent headaches. Some people call that rebound. The technical term is medication overuse headache. And in general, what we recommend is when you look at each individual abortive medicine that you're given, you don't want to use that more than 2 or at most 3 days per week. And like I said before, we call chronic migraine 15 days per week. And at that point, what we will typically recommend, what we certainly have recommended for many years, and what we'll very likely continue to recommend, together with or sometimes separate from the new CGRPs, is Botox. It's FDA approved specifically for the treatment of chronic migraine, and it's really not used in people who are what we call medication naive, people who have, not really tried other preventives. Many times, trying an oral preventive is all you need. And going through with this kind of more invasive treatment would be something that we would avoid if you could. The side effects are minimal, and one of the things that we know is that there is a cumulative effect, which means that the first time you get the Botox done, it only helps a little bit. Each time you do it, there is subsequently further benefit. One important thing to know about Botox is, as you see from the slides, it's a bunch of injections. It's technically 31. You see the little spots in the pictures, and those are the areas in the muscle groups where we inject for Botox. And Botox is still, I would say, the gold standard treatment for chronic migraine. And we'll see with regards to access, whether the new CGRP medications are going to be more in favor over the next few years with regards to insurances even, or whether it will be Botox. That's a big question for all of us. Our patients that are doing well on Botox are doing well, and we're not switching them, but for some patients, they may have to. Going on to what we were calling rescue medicines. So there's something called rescue medicine, which is where you've been doing well with your migraines up until a certain point. These are what we call bridge, or the technical term is short-term preventive medicines. These are things that we typically don't want you to use for long periods of time, but we'll actually give them to you for a week or 10 days. And a lot of times your doctor will say, here, take a course of steroids, and you're thinking, why steroids for a headache? And the reason why is because it'll break up the headache. Sometimes we'll use anti-inflammatory medicines, sometimes anti-nausea medicines like Reglan. There are some other medicines like some kinds of antidepressants or even antipsychotic medicines that we'll actually recommend to patients if you're in a really bad rut. Sometimes we'll even give IV medicines. It'll either be given in an emergency room, an infusion center, or sometimes as an inpatient in the hospital where you'll actually be admitted to a neurology service. Usually it'll be a round of medications that include anti-nausea, anti-inflammatory, and sometimes even anti-seizure medicines like IV Depakote, or sometimes people will even give IV Keppra. Dihydroergotamine is a really strong anti-migraine medicine. DHE is what we call it, and it's something that we'll use as the mainstay of IV treatment for people who are doing very poorly in the short term. So that was kind of the prevention part of it. The what to do if things are worse, but maybe not needing to switch around your preventive medicines. That's where the bridge medicines or rescue medicines come in. And now we're going to talk briefly about some of the acute medicine treatments. And I think that most of us are aware of some kind of triptan. They go by the names of things like Imitrex, Maxalt, Axert, Emerge, etc., Frova. All of them have somewhat different properties. They do work very well and are specific for migraine. So these medicines are specific for migraine as abortives, as acute treatment. The problem is they are profoundly vasoconstrictive. So they are not recommended in people who have vascular disease. Things like heart attack, chest pain, a history of stroke or vasospasm. And for many other patients, or sometimes in conjunction with triptans, we'll recommend anti-nausea medicines. And the reason why they help, they don't only help the nausea part of migraine, but they actually help the migraine part of migraine, the pain also. And they will help to basically treat the underlying dysregulation of neurotransmitters that's occurring acutely in migraine. Some anti-inflammatory medications can actually really help also. And sometimes, if you're the kind of person that doesn't do really well with only one medicine, sometimes you'll actually have your doctor say, okay, when the migraine starts, take a triptan, take an anti-nausea medicine like Reglan or Zofran, and take an anti-inflammatory medicine like naproxen. You may even be that kind of person where they say treat it really early on, because when you treat it within the first 2 hours, you're less likely to still have this pain later. So those are the classes, for the most part, of acute migraine treatment. And what we like to see is you not overuse any individual medicine, like I was saying before, more than 2 or at most 3 days in a week. When you do start to use it more frequently than that, it can actually increase the frequency and severity of migraine. So that's my little talk on the preventive, rescue, and acute treatments for migraine. And we would definitely like to thank our sponsors for the American Migraine Foundation. They have allowed this webinar to exist. We're excited about where this series of webinars is going to go. And now I'll be happy for the next couple of minutes to take some questions. I think you can drop it in with the chat. Well, I don't see any questions, so my apologies to anyone who sent questions in, and for whatever reason, I just don't see that people are, oh, you know what? Let me see over here. Oh, look at this. I can see the questions now. And the first thing that I see is can't hear anything. My apologies for not being able to hear anything. That was 100% my fault. I did start, and I was unfortunately there was some issue with the microphone that was attached to my computer. So I'm going to just take random questions. This one says, what recommendations do you have for people who are very sensitive to changes in barometric weather? What I typically will recommend people, and I'll tell you the truth, here in New York City, we had one of the worst summers, one of the most humid summers that I can remember. And so many of my patients did really poorly over the summer, and through no fault of their own. More often than not, what we really try to focus on, because there isn't a great way of avoiding weather. Maybe you can move to Arizona or something like that. But even there, it rains. Sometimes. What we'll say is, if you're on effective preventive treatment, it will allow you to be less sensitive to any other kind of trigger also. So, that doesn't mean that across the board you won't have migraines, but what it means is it's just that much less likely for you to, it'll be that much less likely for you to have migraine when it comes. It's all just basically about the likelihood, and that's really, really what we try to accomplish. I'll take another question, which says, can you discuss the benefits and cons of the newly released medicines, Aimovig and Ajovy, and then it just says and. But I think the other one was Emgality. There really aren't significant differences that are strong enough to recommend one over the other. For the most part, what we're recommending for most of our patients is what they can access. So if you can, if your insurance is approving one, then we recommend one. If your insurance makes you switch to another, it's okay to be on the other. If you are, for some reason, intolerant or to one of the medicines, or it's ineffective for you, as far as we can tell, it would be relatively safe to switch from one to the other, and that's what many of us are recommending. So that's what we see. That's what we see right now, and I say you get the one that you can get. I'll take two more. So one question says, curious about CGRP and the risk of cerebrovascular or stroke issues. We're all kind of curious about that too, but for the most part, we don't see any significant risk with regards to cardiovascular stroke. And it is officially recommended by the FDA in all adults. It doesn't say adults that don't have cardiovascular or stroke issues or risks. So for the most part, that is something that we are that we're not limiting the medications to. One of the trials actually did did go through specifically a subgroup of patients that looked for cardiovascular risk and saw no increase in cardiovascular events. So we anticipate that it'll be very safe even for people who have cardiovascular issues. Another question is, when do you determine CGRP treatment failure? I'll tell you the truth, that's kind of controversial. And the reason why, we don't know with absolute certainty is because these medications have only been around for a relatively brief period of time. What I do tell my patients, if they've been on the medication for less than 3 months, I recommend that they stay on it unless they're intolerant to it, and very few are. But unless you're intolerant to it, to stay on for at least a 3-month period of time. Anecdotally, what we're seeing is that people are doing better at the 3-month mark. That doesn't necessarily mean that it's true for everyone. And then I'm getting one last question I was requested, so I will answer this one too. How do I decide what medications are best for me? I think that that's a terrific, terrific question. And I'll tell you the truth. You really aren't going to be able to determine what medications are best for you. Although you can do your homework on the medications, you can certainly ask, family members, friends that you know, what their experiences are. That being said, everybody's experiences on medicines can be very different. What's good for one person can be very bad for someone else. And I think it's really, really important to understand that in general, this question of what medicines should I use, what kinds of treatments should I be considering, even the non-medical stuff, all of this really has to be part of a discussion that you're having with a trusted specialist, somebody who, really has some kind of training, in headache, whether that's a neurologist, whether that's some other kind of headache specialist, trained otherwise. It's very important that you find someone that you can talk to about your own concerns, about your goals. And it's worthwhile having some goals, especially reasonable ones, going into starting a treatment. And you don't necessarily think that everyone, or even most people, or even a very small amount of people, don't think that people are going to end up, completely headache-free just because you started a medicine. That being said, some people do really, really well. And some people fail spectacularly. And I'm humbled every single day seeing, which patients do really well. And I was skeptical at first with regards to the medicine that I would have tried for whatever reason. And sometimes patients who do poorly despite being on very, very good treatment. And it humbles you every single day. And I can't stress more how important it is to understand this really as a partnership. And one of the things that I know I try to tell my patients, and I know that all of my colleagues really do also, is if you're in the category of people who have tried a lot of these different kinds of treatments and are looking for the next thing, don't give up, because your doctor won't give up. And if your doctor is going to give up, go find someone who won't, because I'll tell you, personally, it's something that we're trained, that when we find a problem, we try to fix it as best as possible with, as a partnership with our patients. So to end on that note, I wish you all the best. I hope that you enjoyed this presentation. My apologies about the first 2 minutes, but hopefully I've made up for it. Have a terrific night and enjoy the rest of the webinars. Thanks so much.